Welcome to my channel. In this video I will discuss about vitamin B12 deficiency. So vitamin B12 is required for the DNA synthesis. Also folic acid is required for DNA synthesis. Vitamin B12 serves as a cofactor, that is it helps in conversion of homocysteine to methionine, and also it serves as a cofactor for conversion of methyl malonyl coenzyme A to succinyl coenzyme A. So whenever there is deficiency of vitamin B12, then there is accumulation of this homocysteine, and also this methyl malonyl coenzyme A is accumulated in the body. What are the causes of vitamin B12 deficiency? First one, the most important one, is diet, because it is seen mostly in the strict vegetarian who do not eat the meat or dairy products or fish. So there are liver stores that contain 5 mg of vitamin B12 that is sufficient for 3 to 10 years. So a deficiency for a very long period is required for vitamin B12. And also the daily requirement of vitamin B12 is 3 to 5 mcg. And if a person eats meat, then there are very less chances that the patient develops vitamin B12 deficiency. Furthermore, the next cause is pernicious anemia. It can cause vitamin B12 deficiency in two ways. First one is intrinsic factor deficiency. Intrinsic factor is not produced from the gastric parietal cells when there is pernicious anemia, and antibodies are formed against these gastric parietal cells and lead to atrophic gastritis. When there is atrophic gastritis, then there is no production of intrinsic factor. Furthermore, if antibodies bind to the intrinsic factor and neutralize this intrinsic factor, also these can lead to the decreased absorption of vitamin B12 from the intestine. Important cause is diphyllobothram latum also. It also causes vitamin B12 deficiency anemia. Next is gastric or ileal resection. When you cut the stomach, then it leads to the deficiency of intrinsic factor, and when there is ileal resection, then you are actually cutting the binding site or absorption site from where the vitamin B12 absorbs. So intrinsic factor is not produced when there is gastric resection, or when there is ileal resection, then the vitamin B12 cannot be absorbed in the body. Then chronic pancreatitis, because pancreas secretes certain enzymes that degrade these R factors, and these R factors are bound to the vitamin B12, and therefore when R factors are not removed from the vitamin B12, then vitamin B12 cannot be absorbed. So chronic pancreatitis can also lead to vitamin B12 deficiency anemia. Crohn's disease causes damage to the ileum, and when there is damage to the ileum, then it leads to vitamin B12 deficiency, and sometimes chronic use of PPIs can also lead to vitamin B12 deficiency. What are the features that you can see in vitamin B12 deficiency? First one, the most important one, is macrocytic anemia, and it is actually megaloblastic anemia. We will discuss in the lab findings. You can also see leukopenia and thrombocytopenia. So when these three lines are not present in the plasma, then it is called pancytopenia. So all three cell lines are not produced, pancytopenia. Also it leads to mucosal changes, and due to these mucosal changes, you can see glossitis, and sometimes anorexia and diarrhea. And its deficiency also leads to peripheral neuropathy. You can also see subacute combined degeneration of the cord. In this, there is degeneration of the dorsal column, medial lemniscus system, and spinocerebellar pathways. And when there is degeneration of the dorsal column, medial lemniscus system, you can see that there is no vibration and proprioception sensations, and also there is ataxia. There may be upgoing extensor plantars, and absent knee reflexes. Furthermore, you can also see dementia in vitamin B12 deficiency anemia. So what are the labs that we do? First one, when patient presents to you with fatigue and on examination he is paler and sometimes jaundiced, then you should go for CBC. It shows decreased hematocrit and increased MCV. MCV is increased, and you can also see that there is sometimes pancytopenia, that all cell lines are sometimes, when there is severe vitamin B12 deficiency, then all cell lines are not produced. On peripheral smear, we can see that there are megaloblasts and hypersegmented neutrophils, and these are the main things that help us suggest that this is vitamin B12 deficiency. LDH may be raised because when there are megaloblasts, then they cannot pass through the small capillaries, especially through the spleen, and therefore they break down and LDH is raised, and bilirubin, indirect bilirubin, is actually raised. Vitamin B12 levels are low, mostly less than 200 picograms per ml, and it is also diagnostic for vitamin B12 deficiency anemia. And you can see that methylmalonyl coenzyme A and homocysteine levels are elevated because methylmalonyl coenzyme A is converted to succinyl coenzyme A in the presence of vitamin B12, and homocysteine is converted into methionine in the presence of vitamin B12. So these are not produced, and therefore methylmalonyl coenzyme A and homocysteine levels are raised. You can see on bone marrow biopsy, that is usually not necessary, that there are megaloblastic changes in the erythroid series, and also you will see that the cytoplasm continues to grow. While the nucleus shows retardation of nuclear growth, and this retardation of nuclear growth is due to impaired DNA synthesis. So due to this impaired DNA synthesis, the nuclear growth retardation is seen, and cytoplasm continues to grow, and this leads to abnormally large cells and asynchronous maturation of the nucleus and cytoplasm. What are the differential diagnoses for this? Folic acid, we can detect it by detecting the levels of folic acid in the body, as well as in case of folic acid deficiency, homocysteine is increased while methylmalonyl coenzyme A is not increased. And also we can differentiate this megaloblastic anemia from MDS by seeing it on the peripheral smear on the basis of cellular morphology, on bone marrow biopsy also on the basis of cellular morphology. What is the treatment? Treatment is IM 1000 mcg vitamin B12 injection every day for 1 week, and then after 1 week, weekly for 1 month, and then monthly for whole life. You can also give oral maintenance therapy because 1% of the vitamin B12 gets absorbed via passive diffusion also. Either you have pernicious anemia, but it is absorbed via passive diffusion, this 1%, and therefore it does not affect the vitamin B12 levels when you are continuously replacing the vitamin B12 levels orally also.